Are you looking to streamline your knee evaluation? Then I think you'll like this video. Dr. Steele has joined me. He's been gracious enough to put on whatever clothes we could find at the clinic, but he's going to show us how to make a knee exam that gets you to the diagnosis quickly so that you can get your patient better quickly. First thing with any exam, we're going to take a look for inspection. We're going to look for any swelling, any deformity, especially if there's any valgus or varus movement of the knee, especially while the patient's standing. Is there any sign of muscle atrophy? The next thing that we'll do is take a look at range of motion, that we're looking for 0 degrees of extension of the knee, passive or active, and then we're looking for about 135 degrees of flexion. A lot of times we'll assess that in a supine position. The other thing that we can do is test the resisted movements for knee extension for the quadricep pushing out, and then knee flexion with the hamstring pulling in. We'd like to see a 3-to-2 ratio where the quadricep is about 50% stronger than the hamstring. That'll provide better stability for the knee. The other thing that we'll want to do is general palpation of the knee. If we start in the front and think of it as a chain, we'll come down through the quadriceps, palpate the quadriceps tendon, is there any tenderness, palpate the parapatellar areas, which are going to be tender in the cases of somebody with patellofemoral pain syndrome, chondromalacia, osteoarthritis. We come off the inferior pole of the patella to palpate the patellar tendon, and finally onto the tibial tuberosity, especially in a youngster. If that tibial tuberosity is tender, we're thinking about Osgood-Schlatters disease. And certainly if the inferior pole of the patella is tender, we're thinking about Sinding-Larsen-Johansson disease, where those growth plates start to get pulled away from the bone. When we talk about the medial aspect of the knee, we'll palpate the joint line. That's probably one of the more tender areas in general. So tenderness along the medial joint line, one of the most common findings that we can see, and it could indicate that somebody has osteoarthritis. They could have a little bit of irritation to the medial collateral ligament, or there could be a medial meniscus injury. Any of those are going to produce tenderness. The same thing on the lateral aspect of the knee. If there's irritation to the lateral collateral ligament, or if there's irritation to the lateral joint line, those are going to be tender too. Don't forget, on the lateral aspect, we want to palpate the distal iliotibial band. As that band comes down through the knee and traverses over the top of this really sensitive fat pad here, excessive compression makes it tender. The next thing that we'll assess is the back side of the knee. So if Dr. Steele flips over, we're going to take a look at this H basically. Remember, the gastroc tendons are coming up and inserting up onto the femur, whereas the hamstring tendons are coming down and going to be inserting onto the leg. So we'll palpate those tendons to say, is there any tenderness on the sides of that H? And we'll certainly pay attention to the center of that H, which is the popliteal bursa. Remember, the popliteal bursa often communicates with the internal aspect of the knee as well as the other bursa around the knee. Think of it as a series of lakes and rivers. If one's too full, the fluid moves through the river to the next one, and the one that has the least pressure is this popliteal bursa and often blows up. That's called a Baker's cyst, and it's indicative that there's some swelling either within the joint itself or in one of the bursa around the knee. But it's an indicator in somebody with an acute injury. Maybe there's been a damage to the ligament, and in somebody who's older, maybe there's some osteoarthritis of that knee. So that's our palpation of the area. The other thing that we'll do is an assessment of the mobility of the joint. The main joint that we want to look at, a lot of times that patellofemoral joint and the tibiofemoral joint, we're going to assess through orthopedic tests as far as their mobility and stability. But the one joint that we definitely want to palpate is the fibular head. That if we come out on the fibular head and rock that patient's foot back and forth, we can say, does the fibular head work? We can also do an oscillatory movement up and down with that fibular head to say, is there mobility? Don't forget, a lot of our patients have tenderness there, and that's just kind of that blocked feeling in the knee, discomfort when they're walking and squatting and moving. Then we move into the big show. That's the orthopedic assessment of the knee, and we'll think of that by differential diagnosis. In practice, we're probably going to do all of our standing tests next to our sitting tests, and then the supine tests, and finally the prone tests. But I think this video will work better if we talk about it diagnosis-wise. So I'll cover the most common diagnoses that we're going to look at. The first one is a ligament damage. So if Dr. Steele flips over, we're going to assess a bunch of ligaments in the knee. The first thing that we can do is a posterior drawer test, having that patient bend their knee about 60 to 90 degrees and simply shearing back to say, is that posterior cruciate ligament intact? We can do the same thing with the anterior cruciate ligament with an anterior drawer test, pulling forward. And I'm looking for laxity. Don't forget, we want to compare this from side to side because somebody could have looser ligaments on one side versus the other, which would be indicative of a problem. The other test that we could do is Lachman test, and in this case, we're simply going to take that patient's leg down into a little less of a bend, about 30 degrees, and pull on it. Some people will do Lachman's test in an elevated fashion as well. All of those are going to show us a similar process as to, is there any laxity in that knee? A great test to determine is there any laxity or is there a rupture of the ACL is having that patient straighten their leg, dropping your fist underneath their calf, and then pushing down on their quad. What we should see is that their leg comes up. This is called the lever sign. In somebody with an intact ACL, it works well, but if the ACL has been ruptured, we're not going to see movement. The last things that we'll do for ligamentous stability is doing a valgus stress test, taking that patient's knee first locked and applying a lateral to medial force, and then about a 10-degree bend with a lateral to medial force. We'll do the same thing on the opposite side here by applying a medial to lateral force with it bent and again with it locked. And we're looking side to side, is there any laxity on either of those processes? The other thing that we'll look at is the iliotibial band. At the iliotibial band, where it's tender coming down here, what we can do is apply a little bit of pressure over that band, take that patient's knee up into 30 to 40 degrees, and then extend it. And as we're coming back and forth with that additional pressure, somebody with iliotibial band syndrome is not going to like that. And then we'll also use Obers Test. In Obers Test, the patient is going to be in a side-lying position, and we're simply going to take their leg back and have them then drop it down slowly. And what we'd like to see is that the knee that's dropping gets behind the opposite knee. Somebody who has excessive tightness in their tensor fasciae lata or gluteus maximus is not going to get that low. That tells us that there's tension in the muscles that support the band. The other thing that we'll assess in the knee, one of the big things, is the meniscus. And the meniscus can be assessed with a number of tests. Number one, we can do McMurray's test. McMurray's test is taking that patient's leg up, applying a lateral to medial force, causing internal rotation of the knee, and then extending it. I'm looking for, is there any click, is there any pop or discomfort with this, assessing the the lateral meniscus. Then we're also going to do it the opposite way, and in this case, I'm going to apply a medial to lateral force, also externally rotating the leg and taking it from flexion into full extension. And in that case, again, is there crepitus or discomfort? Now, when it comes to the meniscus, fortunately, we have a really good test for that one. And that test is done standing. So this is a really simple test. We're going to have that patient then stand on one affected leg. He's going to bend down a little bit, and now he's going to twist back and forth. And that's called Thessaly test. Thessaly test is 94 to 96% accurate for a diagnosis of a meniscus injury, so something that's really useful for us. The other thing that we can do for this is EG's test. Now, EG's test is having that patient completely externally rotate their feet and squat down, and then completely internally rotate their feet and squat down. If there's pain or crepitus, it suggests a medial or lateral meniscus injury, respectively. Now, squatting is one of those things that's very characteristic of a meniscus injury. If we have the patient do a deep squat, a meniscus will typically hurt at the bottom of that squat. That's something to remember, because if it's patellofemoral pain, it will also hurt with a squat, but usually in the process of going up and down as opposed to down at the bottom. So we'll want to remember that one. We'll also look for tendinopathy. Tendinopathy would typically affect the quadriceps tendon or sometimes the patellar tendon, and oftentimes there's tenderness. So if I palpate the patellar tendon and there's tenderness over that area, the patient notes how much tenderness it is, and then we're going to have them squat, and I'm going to palpate again and apply a pressure. If that tenderness tends to fade when they're squatting and I'm applying pressure, then that's a test that suggests there's probably some degree of patellar tendinopathy. And then finally, we'll take a look at the most common cause of knee pain, and that's patellofemoral pain syndrome. It means that the patella is probably not lining up properly with that femoral groove, and it's getting rubbed, especially against the lateral aspect of that patella. So there's a number of things that we can do for that. Number one is the squat. It's going to hurt when they go up and down. But number two is motion palpation of the patella. So we'll do that with the patient lying down, and I'm going to see how well does this move. The way that I'll do that first is simply by trying to lift that patella off and say, how tight is that retinaculum when I'm lifting the patella off of the femur? The next thing that I can do is, typically it's the lateral retinaculum that's too tight, so I can translate that medially, and I'd like to see this patella move about 1/4 of its distance across, and it moved really well there. Somebody who has a really tight retinaculum, it's going to be tighter. That means it's probably being pulled against the lateral aspect, rubbing against that lateral femoral condyle and causing discomfort along the way. The other thing that we can do for patellar tracking is just simply have the patient sit up and say, where does that patella fall? And now as they extend their leg, where does the patella stay? Is it tracking? This is a test that I don't use very often because I think there's a much better way to say how does the patella track, and that's simply having the patient perform a squat. So we have that patient stand on one leg facing the camera and then squat down. And what we're really looking for is what happens to his leg. Does his leg dive medially or does it stay stable? One of the things that we'd like the patient to do is imagine they're being pulled up by a string when they're doing this, and then squat down. So keep your back up nice and straight and then squat down. And somebody who has hip abductor weakness is going to allow that knee to dive inward. As it dives inward, that seems like a benign problem, but it's not. What's happening is when your knee's coming inward, it's putting stress on the medial collateral ligament. It's tractioning that patella laterally. It's also causing internal rotation of the femur, which torques the ACL, which also torques the shin, leading to shin splints, and also causes the arches of my feet to fall, which is another perpetuator of that functional deficit of patellofemoral pain syndrome and a lot of diagnoses that happen from the waist down. So having that patient perform a squat is part of a functional exam. The other thing that we'll do is to watch them walk, and we don't need to do that here, but when we're walking, we're saying, what's happening to the arch of the foot? Does the arch of the foot stay or does it pronate? Because if it pronates, that same chain in reverse happens where there's internal rotation of the tibia causing internal rotation of the femur, which allows the knees to go into adduction and puts a lot of stress on the hips and the knees and the feet. Don't forget that most of the time the knee is a result of what's happening at the hip and the feet. So we want to pay special attention, taking a look at what's the hip abductor strength by having them squat, and what's the stability of the foot with the hyperpronation. So those are the functional evaluations. We certainly want to take a look at the lumbar spine with your typical test because 1/4 of knee pain comes from an asymptomatic lumbar spine. So we'll assess for any sclerotogenous referral, which is a little difficult. Assessing for a radiculopathy, not nearly as difficult. We'd look at 2 nerves, and that would be number 1, the femoral nerve lying face down. And if the femoral nerve is irritated, we could do a femoral nerve stretch test, which is basically a yeoman test, bringing his hip to his heel and then lifting his leg off the table and saying, does that cause a neurologic pain into the leg? And the other nerve that we would look at is the sciatic nerve. And in this case, we're going to do a straight leg raise. If that's tender, it's either radicular, but it could also be a hamstring. The way we differentiate that is by doing Braggard's test. If the pain gets worse, it's not the hamstring because we didn't do anything to the hamstring in that case. It's solely the sciatic nerve. And in that point, we dive deeper into our neurologic assessment, looking at the myotomes, the dermatomes, and the reflexes. I hope this recap helps you put together a quicker knee exam, something that's more efficient to help your clinical outcomes. I'd love to hear what you do in your exam that's different from mine, and I'll look forward to talking to you next time.